Hey friends, thanks for joining me, Jim Baroud, to hear a few insights from leaders who represent our innovation ecosystem. Today's chat is with Richard Marlink, the director of the Rutgers Global Health Institute. He is among the top worldwide experts in population health.
I came to Rutgers from Harvard, where I was for 30 years. I guess it's kind of like what Gilligan's Island, you thought that it was going to be a 3-hour tour in my training as an oncologist there at Harvard. But I got into a laboratory at the end of my oncology fellowship with Max Essex in the Harvard School of Public Health, where he's a veterinary and his group were veterinary virologists studying viruses in animals that caused cancer, which was controversial at the time. That could viruses cause cancer? And they were familiar with this type of virus called a retrovirus in animals, very common. If you have a house cat, 40% of cats have an AIDS-like retrovirus that are specific to cats. So many mammals have these viruses. So when the AIDS exploded onto the scene and no one knew what caused this epidemic in the early 80s, Max's group and Bob Gallo, who worked closely with him, they said, well, this is a retrovirus because we know they exist in animals. So it's just one that unfortunately is in humans because it's acting just like the animal viruses. So that was quite interesting. I didn't think I'd be in the laboratory. I saw myself as a clinician, which I still do. But I was a clinician in a group of people that didn't have any clinicians in the group, and they were discovering viruses in Africa, which they thought were going to be viruses from monkeys and apes, but then they found new human viruses, new AIDS viruses. The second of which was found in Senegal by our Senegalese and Harvard and French colleagues. And so I was just a young oncologist, but knew how to see patients, human patients. So I actually had some purpose in this group rather than being a trainee in the laboratory, and went to Senegal to see if people with this new AIDS virus were sick, like they would be with the original AIDS virus that was spreading in the early 80s. And that really got me hooked on, I guess, helping out in countries and areas that really need help, and a little bit can go a long way in that setting. And at the same time, trying to discover with partnerships, new science and new issues around public health that would solve problems that were causing pandemics at the time and still are, as we're now living through a pandemic. The AIDS pandemic has killed millions. And the opportunity to do something about it really ends up being in Africa because the treatments weren't there and they were in the US. So it really got me hooked early on working in Africa on solutions to viral pandemics.
And that brings you to today, right? So that was your background. So how did you get here and what are you doing these days?
Rutgers is a big place. They have a lot going on in global health, but they didn't have a central institute or a central effort. Rutgers goes across New Jersey in many campuses, 2 medical schools, 2 nursing schools, lots of different, 29 different schools actually. And many people are involved in global health across Rutgers. Hundreds of faculty, in fact, not just in the health sciences, but environmental health and other areas that are doing something and researching or teaching or having impact on global health. And that sort of was very attractive to me to come to sort of say, could you herd cats? And that's what we do in academia. We herd cats. We can't tell people what to do, but we try to get people going in the same direction and solve problems together. And Rutgers has hundreds of faculty and many, many thousands of students and trainees to help solve problems. And it's a place that's, it's in its DNA to actually have an impact. not just be the ivory tower research university that it is, not just be a great educational experience, which it is, but actually the third part of a university's mission is to have service and to actually do something in the communities that you're in, and in the settings that you can have impact. And for us in health, that's the definition of global health, is have impact for communities of need, whether they're in New Jersey or whether they're in Africa. So that was the attraction to come to Rutgers, and actually help Rutgers have impact in these areas.
That's great. And it's so your focus now is when people hear population health, what does, to the layperson, what does that mean exactly? What's your impact now?
Yeah, population health and public health for that matter, those are sort of broad terms that no one thinks of themselves as part of the public. The public is out there somewhere. I'm not part of the public, or the population is. So these large terms are basically, make people feel that doesn't involve me, but it ends up, obviously involves all of us. We're all part of a population or a group of people, whether it's our own small family, or whether it's the community around where we live, or whether it's the ethnic group we relate to, or whether it's the country we belong to. So we're all part of a group, and it's really how are we affected as a group, either positive or negative, in terms of our health. So many times, health inequity, the lack of access to health, the conditions that would create health, or health care, lack of access to health care, many times is on a community or population level, and it may be determined by where we were born. If I was lucky enough to be born in a wealthy community in the United States, I have access to many things: job, probably good education, a house, lack of discrimination. And if I happen to be born in the urban setting in a poor minority community, I don't have that access. So even in our own backyard, let alone in poor countries in Africa or elsewhere, where you were born or the color of your skin should not determine what your health and access to health should be. And that's on a large level, that's population health. Now, on the positive side, we can have impact to entire groups if we work in public health, basically. And so it can be positive or negative, but global health is the striving to make it a positive endeavor, and to solve inequities in health, whether they're in our own backyard or in another setting, another country.
Got it. Thank you for that. And I should note that, you've saved so many people, and that you're very humble. You don't mention this, but I mean, just the fact that you saved, over 500,000 lives in Africa is really remarkable. And so we're thankful for that. Speaking of impact, we're in a pandemic, 500,000 people in this country, millions elsewhere have been affected. Talk to us about, as a population health expert, how are things going? Are we making good progress? Are you hopeful?
Well, as of today, now we have in the U.S. 3 vaccines approved for emergency use. Recently, the Johnson & Johnson on February 27th was approved, and many people are feeling hopeful with vaccines being rolled out. In terms of global health equity, though, it's a huge tragedy in terms of how vaccines are going to be rolled out or being rolled out now. And that is, we and other Western nations, have bought enough vaccines to vaccinate our populations several times over. That's great. but that's not going to solve the pandemic. This is a global pandemic that's going to require the world to be vaccinated, and that is this is a virus that moves quickly, that has variants that are being is part of evolution, that their variants happen, genetic variants as the virus mutates within each infection, with it infecting each individual. There's so many replication cycles of a virus, literally millions and millions happening daily, so that mutations are common, and viruses evolve in fast forward, where our lifespan is one generation is many decades, and to a virus, a generation is measured in minutes or hours. So if we don't stop the virus worldwide, we're going to continue to deal with variants, continue to deal with waves of infection that we're not, even if we're all vaccinated, we're not going to be protected against. So in a selfish way, we still have to deal with this globally in terms of vaccination in in an equity way, and in a way that's fair and for social justice. We should help everybody respond to this, because it's doable. It's not going to cost that much money to vaccinate everybody, and the vaccines work really well. And it's just like with the AIDS treatments that came about at the end of the 1990s. We realized we had the treatments, and most of the poor parts of the world did not have them. These were life-saving treatments. Then we realized actually it's doable. You can scale up those treatments in any country, in any setting, and it's not that expensive, and it actually saves money for that country or for the effort. If you get onto the AIDS treatment, go back to a normal lifespan and go back to work, you actually, countries can not afford not to be having national AIDS treatment programs. The same for vaccines. They're going to actually save money, obviously, to prevent infections, people getting back to work, people not dying from COVID. So these programs, on a selfish way, we got to vaccinate the world so that variants don't come back and infect those of us in the United States. On an unselfish way, it's the right thing to do. And on an economic way, it's going to bring the economics of the world back to where it was before, because we're in interrelated world economically, especially, and our raw materials, our own economy is so tied in with other economies. We need to realize that it's going to save money actually to vaccinate the world and get everybody back on track. So whatever those three lenses, selfish, unselfish, or economic, we've got to vaccinate everybody on the planet.
Well, and clearly the economic impact is tremendous, right? There's the numbers range up to $24 trillion it's cost the planet, right? So the vaccines are a very, very minor fraction of that amount. So, but do you have hope? I know you're friendly with Dr. Fauci and others. Do you have hope with the new administration that they will be more inclusive and go on this path of global inoculations?
Yes, I do have hope, especially with this administration and with also keeping Tony Fauci at the helm with the new folks that have been brought on board with the Biden administration, and the fact that one of the first things that President Biden did was re-engage the World Health Organization and commit to its mechanism that it does for getting COVID-19 vaccines to poor countries. It's called COVAX. It's a consortium of the World Health Organization, Gavi, the Global Alliance for Vaccines, and another alliance. And they've joined together to actually both raise the money from the international community, but then actually facilitate getting those vaccines purchased and to Ghana or to Sierra Leone, who are some of the initial countries that are benefiting from that international COVAX effort. So I have a lot of hope, but it's woefully underfunded, unfortunately, and like many international initiatives and new ones, it's hard to get the money to do those things, get countries to pledge, but the US has pledged it will be involved. And so I'm hopeful that we'll, rise up and contribute more money to that type of effort. Right now, if we go into a year from now, 9 out of 10 of the people in the 70 poor countries, the 70 of the poorest countries in the world, will not be vaccinated if we continue the way we're doing right now. So we'll be sitting a year from now worrying about getting Americans vaccinated. The ones that want to be vaccinated will have access to the vaccine. We'll be looking for pockets of people that need the vaccine or want the vaccine. But the rest of the world, 9 out of 10 will be really unvaccinated unless we step up to the plate and fund these international efforts like COVAX. Those are the letters that it stands for. Excuse me. So I have hope, but we've just started stepping in the right direction with this, with our Biden administration.
Well, I've read stories about China funding vaccines in developing countries around the world. How do you view that as a population health expert?
Well, any efforts will work. We don't know if the vaccines that have not gone through the rigorous testing and protocols for safety and evaluation of open data from those testing and protocols that the FDA demands. The FDA is really one of our, in the United States, one of our secret weapons, that really does a great job at excuse me, protecting us and making sure new products like vaccines are safe. The FDA does not exist in, China or India or Russia. Now, they may have vaccines that work. Apparently, the Russian vaccine works. We don't know exactly how well, but because we don't have access to the data, but it seems to work. We're not sure how well the other vaccines work. But if it helps in this worldwide emergency right now, let's work together as partners to try to, get vaccines distributed. So it's not closing the door on the fact that these countries don't have an FDA level of scrutiny, but let's don't close the door just because they don't, and let's utilize what works and get most vaccines are better than no vaccine. If you can get a vaccine in someone's arm, then you can see if it works. But if you're going to stop it from getting distributed, you'll never know.
Sure. So tell us, this is sort of the question that's on everyone's mind, is when will we get back to normal? Maybe give us a best case scenario and a worst case scenario.
Well, I hate to say the same thing that probably others say, is that it depends on your definition of normal. When will we get back to what life was like before 2020? I don't know if we will. For those of us, it's like going through the Great Depression or going through a worldwide pandemic that may end up killing 1 million Americans. We're way over 500,000 now, and it's not under control. Yes, it's plateaued out, but it's plateaued at too high a level, and we're still worried that vaccines haven't scaled up to be able to release restrictions the way people would, obviously, myself included, we don't want to be restricted the way we are. But would we go back to not worrying about this in our own psyches? No, I think we're going to worry about it the rest of our lives. And so would that change how we do? I think, the unfamiliar handshake may be a thing of the past. The seeing someone in a mask, that used to be unusual, very unusual in the West, maybe not in other areas that dealt with SARS before or dealt with respiratory epidemics. But I don't think seeing masks will be unusual at all now, going forward. Now, is that normal? I don't know. I think it'll be the new normal. Will we get this pandemic under control? Yes, we will.
Okay.
Will it be by a certain date? I don't know. I am hopeful that the vaccines obviously will be available even faster in the United States than we predicted just a month ago. So the main challenge in the U.S. is getting it to populations that are hesitant and don't trust the medical establishment for good reasons, and that are hesitant or are hard to get to. If you've got to show a driver's license or some identification to get a vaccine, but what if you're homeless? And what if you don't have a driver's license? And what if you're in a poor community, you don't have a car and you can't drive to the vaccine mega site? So we need to be looking at getting to populations that are hard to reach, and talking with and listening to groups that don't trust the medical establishment. Through the Tuskegee experiment on African Americans, men with syphilis, withholding curative treatment while you watched men suffer from the problems of chronic syphilis. That's an unethical study that the U.S. government conducted in Alabama, and did it for decades. So that's sort of mistrust, I guess, of the medical or research community, or community that's going to say, I've got a shot for you, I'm going to stick it in your arm. It's understandable that people are hesitant to jump on board to a new treatment when they may not have access to basic health care and don't trust the health care that comes in from outside their community.
Yeah, and let's talk about that a bit more. But before we do, Rick, tell us about the variants. How concerned should we be about? We hear about new ones almost every other week. I just heard about one in Italy that's, spreading amongst young people. So what should we know?
Well, I guess overall we should step back and think that, or remember, we're just beginning our dance with this virus. And when I say dance, any infectious disease and its host, we're the host in this case, unfortunately, and they're the infectious agent, and its host has a balancing act that they start really for survival. And it's not that the virus is thinking anything, it's just that it's Darwin's principles of the survival of the fittest. The virus that's more contagious will spread more easily than the virus version that's not as contagious. So it's the survival of that version. Just mathematically, it goes on to reproduce itself in another host and spreads. So as these viruses are new to us, they're learning quotes around that, because as a genetic entity that's spreading across the planet, the ones that know how to survive, know how to infect better and spread faster. So as a group, the virus is learning how to adapt, and we're learning how to adapt. In fact, our immune system, one way we adapt is by triggering it with a vaccine. So we're actually using our brains to adapt and create a vaccine, and we're essentially goosing up our defenses because we don't want to wait generations. We reproduce slowly compared to the virus, and we don't want to evolve to be able to fight this off like we did for other coronaviruses. In fact, there are other viruses related to the COVID-19, the SARS-CoV-2, that probably initially may have caused huge pandemics. There's thought that one that caused probably the death of, again, maybe 1 million or 2, but as it calmed down, it turned into the common cold, over a century. And so these other coronaviruses, that's the class of virus, there's at least 4 that cause the colds. And we probably, many of us as kids, all have had of cold from a coronavirus. So the virus will move towards surviving, which means more infectivity. But the virus itself, the mathematical equation for the virus is not to kill us. That doesn't help their equation one way or the other. So they usually would evolve towards not being as much damage to our immune system. And our own immune system would evolve towards being able to fight off the virus. So if you look at the crystal ball, we will evolve for several reasons towards having this cause less disease. 1, we'll get vaccinated. 2, our immune systems will learn how to deal with it. And 3, the virus itself won't want to evolve towards killing us more. But it will evolve as to be expected. The same thing happened with HIV. It evolves towards being more contagious. And so in HIV, the subtype that is now worldwide was a minor subtype back when we first started studying in Africa. It replaced the others. There's 5 big subtypes of HIV, and one of them is the most infectious, and it has basically replaced the others. And it outnumbers the others put together now. So these variants are going to probably replace the ones that exist over time. We just don't know how fast. If we can get ahead of it by vaccinating against it, our vaccines will still work. Seems like they work somewhat, but probably not as good. But still, if we can get ahead of it and slow it down, we'll slow down the spread of the variants, and we'll also slow down the creation of new variants.
Got it. Now, you spoke about inequity. I know you're working on some programs throughout the state. Can you talk to us about those?
Well, yeah, Jim. The big thing is this pandemic has exposed what already existed, which was the inequity to health and the conditions for health in our communities across New Jersey, across the country. But we're focused on New Jersey as our backyard, and New Jersey has one of the highest social indexes of, the wealthy being right next to the not wealthy. So the income disparity in New Jersey is quite broad or high, quite high. So in those communities, low income communities, usually minority communities, may not have English as their first language or whatever. The access to health already was lacking or difficult. Now we saw that the access for testing initially was not available in minority and low income communities, and the access now to vaccines will be the same. So we're trying to deal with in our setting, how do you keep people healthy? Well, the best way is to have them have a job, have a roof over their head, have some good food and education. Well, if all that's taken away, and it is in many small businesses and in many minority communities in this pandemic, you're going to have a difficult life, just have the bottom drop out. So lack of money for rent, for food, on top of schools are closed and schooling needs to occur at home. But what happens if you are having trouble making your home payments? So we focused on where we thought the need was going to be great, and that's small minority or women-run businesses in poor communities in New Jersey. So We launched in New Brunswick a pilot, and it's worked very well. In fact, the demand is very high, so we're both not calling it a pilot anymore, and we're looking to expand to other city settings in New Jersey, that cities with high poverty levels. Newark, Camden, our own Rutgers home cities, along with New Brunswick, have high poverty levels in each of those cities. Trenton, Patterson, other communities, again, have high poverty levels, and they naturally would have businesses that are going to be struggling. The small businesses that to keep people employed would be the best thing for their health, rather than have the small businesses go under or not be able to function properly and have the employees feel safe, have the customers be safe. So we're focused on training small businesses, both virtually with live virtual training and then on-site consultations. And then thirdly, hooking businesses, their employees, and the families into supportive services for all the other things that this pandemic has affected: food security, schooling, help with finances, taxes, mental health, and physical health issues. So we have a resilience network in New Brunswick of people that are already doing those, organizations like Elijah's Promise, or University Behavioral Health Systems, or Eric B. Chandler Clinic, or New Brunswick Tomorrow, or many services are already there. And how do we, almost like a patient navigator, get the people that need those into those services? That's the third part of the program that we think is just as important as the safety training during, for businesses and their employees.
Sure. Thank you for explaining that. That's very impactful. Before we get to questions, and we have questions from around the world here, tell us one thing that we should all take away from this conversation.
Yeah, I guess the one thing is, health inequities are limiting entire communities and entire countries from realizing their potential. Many times these health inequities exist just because of the color of one's skin or where one was born in the world, or both. So these inequities have profound economic and social costs, not to mention the fact that it's heartbreaking to know that in many places in our own communities and around the world, people are dying of completely curable or preventable conditions. So it's really up to all of us to address this and do it in a partnership way, in a kind way, and listening to each other. We can correct the inequities, but we have to get to their root cause.
Great. So speaking of partnerships, you spoke about the programs, throughout the state. Talk about who are some of the partners. Are you working with the government? Are you working with the private sector?
Well, in the state, in New Jersey, working with, I guess, local partners. We'd like to replicate that again. Rutgers may be all around the state, but really where solutions are going to happen are in the neighborhoods and the communities and people that know those neighborhoods and communities well. So the partners need to be of those communities that are a part of the program. In our case, we call the Equitable Recovery Program. So that would be everything from the Department of Health, either the local Department of Health or the State Department of Health, to help us with COVID-19 free testing. The local NGOs, non-government organizations that may be affiliated with the hospitals or with behavioral health services, or may be standalone. there are community organizations that are specific to different communities. PROB in New Brunswick started very specific to the Puerto Rican community in New Brunswick, but there's other community groups that are specific to overall to Spanish-speaking communities in New Brunswick. So those are our partners that would be really the people that are from and know the communities in need.
Got it. Thank you. So here's a question. What are some of the technologies that were instrumental in identifying, treating, and triaging patients during this pandemic? And more importantly, perhaps, how will we be prepared for the next one? And they're saying there will be future pandemics. I'm sure you agree with that, but can you talk about that?
Well, I guess I can step back because I'm old and I can use the previous pandemic that still exists. So I think a lot of the progress that we were able to make with this pandemic is due to our work on the HIV pandemic and progress that we're making even in cancer and other areas in immunology or genetics or in new treatments has been hastened because of work around HIV. That is, HIV is a retrovirus that incorporates into our DNA. And that's why it's been so hard to get a vaccine against it and really cure anybody, because it really becomes part of us. But that means we need to understand our own genetics a lot better. And we have a long way to go, but we've learned a lot about how to treat a virus through because of HIV. That's through investing in it, through the private sectors and the discovery drug companies really creating treatments against HIV showed that you could fast track molecular biology into treatments. And now those same companies many of them have fast tracked the new treatments that were being developed for other viruses or for cancer. They said, well, wait a minute, here's another infection that could use some of the treatments, whether it's monoclonal antibodies or antiviral treatments that we had developed originally thinking for HIV or for cancer. And let's work them into fighting this coronavirus, the SARS-CoV-2, the COVID-19 pandemic. So I sort of say that the industry, whether it's the public industry, the one funded by the U.S. government and academia, and the private industry, the pharmaceutical companies and biotech companies, all were sort of poised to be able to offer faster solutions because they were actually been working for several decades on this past epidemic and the epidemic of cancer. How do we do with our new genetic knowledge of our own genome and or of treatments, how do we fight cancer with this new genetic knowledge? So how are we going to deal with the next one? Well, this will teach us a lot to how to deal with that. Certainly the next related, coronavirus pandemic we'll be able to deal with, but it'll also help us with flu and other periodic epidemics that we already have. So this, the way we've made vaccines with this mRNA technology, it was working for animal vaccines. It was a new technology, but we knew it worked. I think this is sped up using this type of new technology that will be creating designer vaccines for new things more rapidly because we saw how wonderful the technologies worked for creating, vaccines for COVID-19.
Sure. And I think that's really illuminating for us lay people that we built on the progress made in the past from AIDS and HIV and other pandemics to where we are now, because I know there are some skeptics that say this was done so quickly, when in reality, I think we've been working on it for decades, as you say. Can you talk to that?
Yeah, I think again, I guess the shocking thing for HIV was people realizing, my gosh, this is a worldwide epidemic, and it's really hard to cure. So that actually probably for companies realize, well, that's interesting. So we can actually create a treatment. It may not cure it, but it's going to be needed worldwide. So there's a great incentive, I think, to gamble, which companies need to do to the billions of dollars it takes to gamble that something's going to actually come to market. They usually don't win that bet. they gamble just like entrepreneurs, but on a company scale. They're hoping that the product will work, but many times it doesn't. But they have to they've gambled then for HIV and realized actually we got some treatments that really worked well, and they're really used worldwide, and it put people back to work, and it saved millions of lives. So I think that also emboldened companies to say, we could do this. And then immediately, when the sequence is available for this new virus, the new novel coronavirus, companies from Johnson & Johnson to Merck to all the vaccine companies and Pfizer, they really said, wait a minute, can we do this? They knew what it was going to cost, because they had built it up before for other infectious diseases, or were doing it for cancer. And they said, we actually can do this. The technology's there. We've seen our platform, whichever platform they were using for their vaccine, we've seen the platform work. We'll just have to change things and get the machine, our machine, which involves many people and billions of dollars, move that machine and get onto this problem. And so they knew that would happen. The secret that happened, why it happened so fast, is that the US government said, we will pay for the risk. So yes, to experiment that your vaccine works, then you find the investment to scale up the production. We'll scale up the production knowing that we don't know if it's going to work. So we took on the risk as taxpayers or whatever, but that's why they're poised to already, the vaccines of Johnson & Johnson's approved on the 27th of February. And, 2 days ago, they already had the shipments leaving, not just leaving the factory, they're already ready to go on FedEx or whoever carried them. So they were already made, even though the vaccine wasn't approved. So the shortened time was also that the risk of manufacturing millions and millions of doses was sort of taken off the timetable, and taken off the table as a risk to the company.
Right. And that's really informative, right? I mean, in some ways, this is sort of a case study for a great private-public partnership that actually worked, and so that's really helpful to put it in that context. So there's a couple quick questions about sort of at-home tests. What's the status on those? Will they be distributed widespread, or what's the latest?
Yes, they'll get better and better. Again, they'll be both because of demand and ease, and it'll actually help in terms of curbing the pandemic. If we can, have assurances that our loved ones, our coworkers, everyone in school, can easily just know their test status, and then know what to do if you test positive. But yes, they'll be more and more widespread and easier to use. Be it like a pregnancy test or urine test, a saliva test, they will happen more and more. And
the accuracy will improve as well, correct?
Right. The accuracy, it's the beginnings of any of these platforms that don't have a lot of DNA or a lot of antibodies. That's the serology test. That antibodies are usually floating around in our in our serum, in our blood. But if you're using ones that happen to end up in your saliva or or in your urine or whatever, it's not going to be as accurate. There's not going to be as much of the DNA or of the antibody, whatever you're trying to detect. But they'll continue to improve. But if you do mass, repeated testing, so let's say it only works 85% of the time, which is not great. You want it to be, 99 to 100% of the time accurate. But if you do it repeatedly, you'll eventually get the positive test and say, wait a minute, I might be positive. So today I test negative, even though I'm not negative. But if I do it every morning, tomorrow I test again, I got another 85% chance, let's say. So just the odds, that if I test myself 3 times, it'll be as mathematically as good as if I had a completely accurate test. So if we can get them just widespread, used repeatedly, get them cheap, then they'll have a great place, in the armamentarium, in the armory against this pandemic.
Sure. So what about mental health, right? The studies are tragic. How do you view that from your perspective?
Well, that seems to be the toughest area, and the one that's like the iceberg. A lot of the problem is not seen. When we talk with Frank Ganassi, the head of the University of Behavioral Health, or his medical directors, they see, and the literature is starting to show surveys that, depression among young people is, up 40% from, so 4 out of 10, when before, it'd be less than 1 out of 10 would report deep depression, and even to the point of suicidal ideation or thinking of suicide. So I think this is the dramatic part that's we're only seeing the tip of the iceberg, and we need to plan now or act now to boost those services. Many of the services are increased, but they're from a distance. Again, people are distanced, so it's telemedicine or call hotlines or call-ins. But I think the idea that we need to make that more normal, that we need to seek out help. All of us get depressed, and all of us, it's a normal part of, unfortunately, all of us get sick of something, and the mental problems are part of the human condition, and we need to make it normal to seek out help, because this is really the tip of the iceberg in terms of stress, depression, family dynamics, even violence that's happening in much greater percentages than we realize.
Yeah, and hopefully a fraction of the money spent on the vaccine and the government could be put toward mental health. That would be a really impactful investment. 2 more questions, Rick. Wearing a mask. What's the latest update on how we should view that?
Wearing a mask is good. Wearing 2 masks is better. And seriously, so the masks really help. This is one of the even mistakes that CDC or even Tony Fauci, the recommendations early on were, oh, we better worry about the masks and don't recommend them to everyone because there may not be enough masks for the healthcare workers. So one thing we didn't realize, that's a different type of mask. and yes, we needed both. We needed more, N95 masks for healthcare workers, and we needed all of us to be wearing masks, especially ones that, at least 2 layers, or ones that block your breath from coming out. So the way to test that usually is, again, in our trainings, we do this with the small businesses. You do the candle test, and have a candle in front of you in a safe situation, and you check your mask and try to blow the candle out. If you can easily blow it out, that's the wrong mask. But if you can't really blow it out, that's probably the right mask. And so if it's comfortable and you're going to use it, that's the main thing. The best mask is one that you use. If it's comfortable, you're going to use it, and you can't blow out a candle, you're good to go. If you can do 2 layers or 2 masks, it's the best.
And it should be tight, right? I think people are saying there's sometimes, I know my kids' gaps are all over the place. It drives me mad.
Well, try the candle test. Again, careful with your kids depending how old they are. But I know yours. But they, again, a mask used is better than one that's not going to be used. So, but yes, one that's tight is fine. But so that you're actually breathing through the mask, not around it. Yeah.
Okay. One more question, Rick. This is about someone who's young. It says, I wonder if you can share some lessons for early career scientists. For example, how to identify opportunities and establish a network.
Well, networking is good. The last phrase actually is always good, to get to know everybody in areas you're interested in. And you'll be surprised how many people will network with you no matter what your age is. And because you're interested in something that they're interested in, they're probably very willing to talk about it. But if I was an advice to a young person is don't worry about what you're probably going to be trained in is not what you're going to be doing the rest of your life. So just make sure you follow your passion in terms of interests and follow your heart. And that's what you're going to end up wanting to get up every morning and study, or wanting to get up every morning and work on that issue or that area. And then you'll do well. And so follow those things that you like. More broadly, if you want to get into health or global health or public health, all these things will end up being in health, as I said, from engineering to policy, from working in social sciences to biomedical sciences to laboratory sciences. They're all going to be part of the improvements in health that we need. But I just say follow your passions, follow what you like. And the last thing I'd say, which sounds like a father, I think, but get as many degrees as you can tolerate while you're young. That is, I'd say if you wanted to help the world, specialize, because then you're much more valuable in whatever organization or whatever effort you do. If you are a generalist, which is great, we need to have that broad background, but you're not really well trained in any one area, you don't bring as much to the team, because most of this is going to be done by teamwork. If it's a research team, program project team, education team, if you're specialized, and the more specialized you can get, or maybe multiple specialties, the better. When I say do that when you're young, because it's easier to get degrees. As life goes on, more responsibilities stack up, and it still can be done, and lots of people do it. But get as many degrees as you can, or specialize as much as you can.
Great advice. And it's easier these days than ever to do online education as well. That question, I believe, came from Africa. So wherever you are in the world, this advice is applicable. So let's close this out, Rick. Talk to us a quote or a poem, and we can be on our way.
Yeah, you had said to quote a poem or something that I liked, and a lot of the poems I like might be from dark Welsh poets, or too long, so I'm going to do a quote from a poet. That's Maya Angelou, and who's has great poetry. But I think the idea behind this quote will help us when we're trying to address these hard problems as a group, and trying to not yell at each other and the left and the right, and the have and the have-nots. We have to do this as a group to solve this pandemic. And what she said is, most people know this quote: "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And so we need to have people remember how we made them feel heard, listened to, and be kind to each other. And I think that's the way forward. So that's why I wanted to use her quote.
That is a great way to end, Rick. And I think you've made us all feel a lot more informed and smarter today. Thanks for joining us. I hope you enjoyed the show. Please like it, leave a review, and subscribe. See you soon.